about fetal cardiac MRI, and the topic was supplementing fetal echo. And to be honest, I'm a big fan of fetal echo. I'm going to tell you a little story first about someone who's very close to me, and that's my daughter, Poppy. Now, many of my colleagues who are in the audience have looked after Poppy, including Aphrodite, actually, because Poppy happened to have transposition of the great artery than David did her arterial switch. And why am I showing you her picture? It's because she did not get antenatally diagnosed with transposition of the great arteries, and she was born very, very blue and poorly in saturation of 40% and in a hospital where there was no support for diagnosis or treatment of patients with congenital heart disease, and she nearly passed away. Thankfully, she didn't. She's great. She just wants to be an actress and is a lot of fun. But that was a motivation, not just for our patients, and many of our patients come to us when they are very sick because they haven't been antenatally diagnosed, to do better. So we got a project funded called iFind, and actually it's much wider than just the MRI stuff I'm going to show you. So it includes fetal echo, and here's, for example, some data, again, using machine learning, where in real time, as you're scanning, you can identify the chambers you're looking at and even diagnose the diseases, which will come along to help the people who do those scans, not the expert fetal cardiologists sitting in front of me, but the non-experts, to be able to properly diagnose these problems. But I'm going to talk to you about MRI, and Kibiran showed you lovely pictures of 3D MRI in children and adults. Well, great, but what about fetuses? Well, we have a few challenges here, don't we? One is that wonderful hummingbird shows you not quite as fast as the fetal heart, but the fetal heart's beating at what, 120, 140, 160, even higher. The second question is the fetus going to hold nice and still for us while we scan them? I don't think so. That's very typical. And lastly, the picture in the corner shows you the size of the fetal heart compared to the adult heart. You now show some beautiful pictures of MRIs of those big hearts. Imagine trying to scan that little thing. So that was a challenge for us when we set up this project. And the solution actually came from our physicist, and it's basically called motion correction slice to volume registration and reconstruction. And what I'm going to show you pretty much for the rest of this talk all is built on this. And many of my colleagues, engineering colleagues, have obviously built this over a number of years. But basically, the images you see on this side are all, you can see, misregistered, because that's what happens. The fetus is moving, and you can actually use an image analysis technique to get them to look on the images on the other side where everything's aligned. And of course, with MRI, you can do this in 3 dimensions. And then we applied this clinically. And so this is our initial larger clinical results, published now back in 2019, showing that, for example, and here is the double aortic arch in a fetus, a tiny heart moving away, and you can actually properly see the structures, anatomical structures of the vessels very nicely, and things that can be hard to do on echo. So there's one, aortic arch abnormalities. How about pulmonary venous abnormalities? Again, we're looking from the back of the heart here. The lungs, you can see the descending aorta, and the pulmonary veins are shown in yellow. And as let's click away the lungs out of the way, you will see that the right-sided pulmonary veins are coming into the IVC-RA junction, and the left-sided ones are draining normally. So right anomalous pulmonary venous drainage. So here, in a fetus, in that tiny heart, suddenly we're getting the anatomical structures very clear that even me can understand. Of course, our fetal cardiologist will be able to do this, but for as a simple cardiologist, we can suddenly see what's going on as well. And when you compare these views you get in the fetus to what happens in the way the baby's born, and again, we showed that in that study, you can see it's pretty identical. This is anomalous right subclavian, anomalous right subclavian artery, and the CT image after the baby was born. So again, going back to the radiation thing, maybe we shouldn't have done the CT. We had these beautiful antenatal fetal MRI scans. But there you are. You can see that the anatomy looks very much the same. Now, what about flow? So again, the issue here is when the baby moves, of course, that affects the flow as well. And again, we've been able to show that if the baby is still during at least the middle of the scan, you can get away with getting reasonable flow. But there is this metric optimized gating sequence that we can use as well to get the information to basically oversample to correct for that motion. But if there's motion in the middle of the scan, then it doesn't work and it's inaccurate. Of course, you can apply those same methods that I showed you by correcting for the motion to not only correct for a 2D motion, but 3D motion. So here we've got correcting for 3D motion, and suddenly you can do 4D flow. And this is fetal 4D flow. And of course, that then opens up both the 2D and these 4D techniques, opens up the opportunity for you to be able to measure blood flow on all the fetal vessels. And now we're doing regularly this in our patients. We have now thriving clinical service, actually delivered by Kibiran and another one of my ex-PhD students, David Lloyd. And you can not only get the anatomical information, but flow on the different vessels. And you might say, well, how is that important? Well, let's take a really difficult, thorny problem for fetal cardiologists. For the fetal cardiologists in the audience, how good are you at diagnosing coarctation? Well, it's called the fetal Achilles heel. I don't know if that's true, but Achilles was Greek. Maybe it is true. And 70 to 90% false positives. So you're getting these poor kids who don't have coarctation. You're getting them admitted to the neonatal intensive care unit, observed for a few days. It's not nice for the mums and the babies, and it costs a lot of money. So could we do better? And actually, repeating the fetal echoes, or actually the postnatal echoes until the ducts close, doesn't really help you, does it? So let's look at, we did a study, again, looking at the fetal features by MRI. And if you look here, there's a few key things I want you to look at. So, and I wonder if I could use a pointer. Maybe I can. Let's see if I can use the technology here to show you. Hopefully, there we are. So firstly, and this is basically looking at a false positives and a true positives. You can measure blood flow. You can measure, as I showed you, the blood flow through the aorta, and of course in the descending aorta. You could measure the key angles, and of course, again, from our pediatric, we know about the angle between the carotid and subclavian, the distance between the carotid and subclavian artery is important, and the angle between the duct and the isthmus is important. But also, what is important is the displacement of the duct from the descending aorta. So that distance between the descending aorta and the duct. And if you look at those things between the false positive and the true positive, you can see the differences. And of course, we looked at this in a wide group, and actually that distance between the descending aorta and the ductal insertion was the most significant, and you can show that as a ratio, and the aortic flow. So if I then move on and show you the flow data, if you look at the flow in the aorta between the normal group, the false positives, and the confirmed coarctations, you can see the flow is in the aorta is significantly less. But interestingly, the false positives, the flow is also less, not as much. So they are not normal. So when we say false positive, it's not that they don't have coarctation. They don't have coarctation, need surgery at birth, but there's something else going on. But also, of course, you can look at the flow across the isthmus, and you can see that actually in the coarctation group, that flow is actually reversed slightly. But again, it's reduced in the false positives too. So let's combine those two biomarkers. And actually the best ones probably is flow through the aorta and that distance, the posterior, if you like, displacement from the ductal insertion. And actually, if you do that, you can get a risk matrix where you can nicely differentiate between those patients who have coarctation or very likely to have coarctation, and those who don't. And if you take the 50% risk score, that has got a 93% accuracy, which is so much better now than what you had by just doing fetal echo. So getting you up to 93% accuracy, it's not 100%, but it's pretty good. But do we go for saying, yes, no, this is coarctation? Well, I don't know. Maybe what we should do is to say, what's the risk? And let the clinician and the parents decide. Because if you're in that middle group, then if you've got a risk of 37% or 45%, maybe you still decide to deliver that baby in a cardiology unit and observe them. Now, what are other indications for fetal cardiac MR? Well, one is hyperplastic left heart and restrictive atrial septum, and not so much for the anatomical views, but of course the key point here is that if there is a restrictive septum, and of course there are signs for that, including measuring the size of the foramen versus the whole complete size of the septum, you want to deliver and also intervene early in the child. But there is something else that you could look for, and that's pulmonary lymphangiectasia, and that's very hard to see on ultrasound. And similarly, if you're looking at patients with obstructed TAPVD, again, there are signals you can get from the fetal echo with loss of phasic flow, with increased velocity in the ascending vein. Again, a need for real early intervention. Well, in both those cases, the MRI can also not only give you the anatomy, and here you can see a supracardiac TAPVD, but it can also show you the abnormality in the lung, what's called a NUT-MET lung. And now you can see the lymphangiectasia, and you then know that these patients are at very much higher risk. So that's another group where you can really benefit from the scans. And finally, tumors. Here's a fibroma. You see the left ventricle posterior by the spine, the right ventricle at the front. So this fibroma is anterior. There's pericardial effusion around the heart. It's compressing the right ventricle. You can also try to differentiate what the tumors are by looking at their T1, which is the white blood, and T2, which is the black blood images you see, their characteristics. So it's a rhabdomyoma here. But they have very, teratoma would have a different signal. So you can be able to use the MR signal to be able to tell you what the tumor is. And finally, from using those 3D images of the structures of the heart, you can see whether there's obstruction, for example, in this case, a little bit of obstruction to the right ventricular outflow tract. So again, for tumors, this is really helpful. Now, what about looking at intracardiac structures? I'm coming on to the end of the talk, so just bear with me one more minute. You can see those actually pretty well on fetal echo. Of course, you can see them on MRI as well on the other side, and MR gives it to you this information in 3D. So here's a VSD, and this is what the MRI shows you. The fetal MRI of the intracardiac structures showing you the position of the VSD and its relationship, for example, there to the pulmonary artery. But I don't think that adds a huge amount of value because actually the fetal echo does a pretty good job of the intracardiac structures. Now, Kibiran was just telling me our American colleagues who have patients with very much bigger body habitus who sometimes can't get very good fetal echo views, sometimes are using the MRI for diagnosis of intracardiac structures, particularly for late gestation, but not so sure if that's needed. So finally, fetal cardiac MRI can give you a very comprehensive view of all of the information you need, intracardiac structures, flow, vessels, and it's really helpful for some key things like arch, branch PA abnormalities, coarctation risk stratification, venous abnormalities, particularly pulmonary venous abnormalities, TAPVD, associated lymphangiectasia, and tumors. But in terms of intracardiac structures, I'm not sure. I think actually echo still is the best thing to do in most situations. If the echo gives you very poor views, maybe that's something to use. But also newer methods are coming up which might make a difference in the future. But for the moment, I think echo is great. And finally, acknowledgements. Actually, this work is in large part done by those people on the table, including my wonderful fetal cardiology colleagues, but particularly I should mention Kibiran and David, who are really leading the service for us, and the two key fellows, Milu and Johannes, and all the engineering colleagues on the other side who develop all the technology. Thank you very much.